I'd now like to welcome our second speaker, Michele Alberts, who we're so pleased to welcome back to Touro University. She was actually one of the first people over at Highland Hospital at the time, about 10 years ago, one of the first MOUs that we coordinated as part of our public health program to get NPH students into our traineeship, into our field study practicum. So she is new to Touro University as a professor, but she's been around and has been a part of our program for at least a decade or probably more, right? So again, she's just joined the School of Nursing and serves as an assistant professor. And in addition to her responsibilities here, she's served in numerous leadership roles with the California Association of Nurse Practitioners and the U.S. Lactation, and serves as a U.S. Lactation Consultant in the U.S. Lactation Consultant Association. Dr. Alberts is a founding member of an innovative community health advocacy group working to eliminate health disparities and to increase access to health care in our communities locally. We're pleased to welcome Dr. Alberts.
As was said, I'm an assistant professor here, and my background is that I'm actually from California, and my parents were Catholic workers, and so I grew up kind of in the 80s during the wars in Central America and the UFW and all of that experience. So have lots and lots of both personal and professional experience with working with immigrants and immigration issues. And most recently, my family is going through this very, very personally. And so I'm going to talk mostly from a professional perspective, but I'm happy to answer questions. And so I very much appreciate the lines and the timeline, because there are a couple things I wanted to add to that, because I felt like it was really profound to do it that way. And one of the things that we talked a little bit about was adult children coming over, and also folks becoming naturalized through marriage. And one of the things that happens a lot with folks when they become naturalized through marriage is that they often have come illegally previously, right? So one of the pieces to add to this is that it's such an experience to kind of put yourself out there, right, to acknowledge that, because what happens is that somebody will, in a marriage situation, if somebody has crossed illegally, the stakes are really high, because what has to happen is that the relationship has to get acknowledged by the government. But in addition to that, somebody has to apply for what's called a pardon. And so what happens to that process is that it used to be, the reason this is important is because of the public charge that we talked about, because the issue around the pardon is that if your pardon is not accepted, even though your relationship is, you're automatically banned from the United States for 10 years. So that's just another piece to I want everybody to kind of sit with for a second, because I think that's really important when folks are making, these huge decisions in lots of ways to deal with their issues, their immigration issues. So I have lots and lots of friends and lots of family over my lifetime, really, who have been dealing with this, and like I said, very personally in my own family as well. So that said, currently I work here, but I also work for Alameda Health System, which is formerly Highland Hospital. And we're a safety net hospital in Alameda County, and so mostly what we do is work with folks who have not all immigration issues, but for sure issues around access to care. And like I said, it's a safety net. So we work with patients from all over the world. But I think, in my own experience, both being from California and also living in Oakland, a lot of what I'm going to talk about has to do with the current situation around Mexican and Central American folks, because that's probably the majority of who I work with and what I do. That said, that what I'm going to say applies to lots of folks with immigrant backgrounds who are dealing with healthcare. And so again, I appreciate very much having the background set for us as healthcare providers to both be listening to our patients' experiences, but also to be acknowledging that what folks are having to contend with are super, super challenging. So that said, this is just from a book that was written a while back, but I actually think it's a pretty good quote. So it says, "Fitting is a luxury rarely given to immigrants or children of immigrants. We're stuck in emotional purgatory. Home somehow is always the last place you left and never the place that you're in." And the reason I picked this quote is because we're in the process right now so much of making all these decisions for people, right? I mean, without necessarily including people in this decision-making process. So, so I'm going to talk a little bit about healthcare, both as a practitioner, a healthcare practitioner, but also just to talk a little bit about California and who has access to what and how it works, because I think given your all's understanding or new understanding of how this process works, it's also important to know that those of us who are going to be healthcare providers or who are working in the healthcare system in one way or another, it's important to know sort of what things people have access to. So, and I'm speaking more from the California perspective. Different states are different, but that said, you know, I'll be able to answer some questions. So in California, we have obviously lots of ways that people's healthcare is covered. And the way coverage is allocated a lot in California has to do with people's immigration status, whether folks are legal or, quote, illegal immigrants, right? And whether or not they have access around whether their applications for their status are in process or complete. So in addition to that, people who have temporary status have certain access issues around healthcare not complete. People who are visitors to the U.S. Also have some access around healthcare issues, particularly if they present in emergency situations or they present with an illness. Typically in the safety net setting, what happens is a short-term period of care time is allocated to them. Also safety nets, and when I talk about safety nets, what I'm talking about primarily is like our county hospitals, or what we call FQHCs, federally qualified health centers. A lot of county hospitals are affiliated with FQHCs, not all, but that's more, you know, what I'm talking about as opposed to public health departments, although some of the issues are similar. So that said, there are also immigrants have access to what we call charity care in a lot of settings, which basically is a way that counties will sometimes recognize folks that don't have any other access to care. So what I mean by that is states allocate a certain amount of money to counties and folks that don't qualify, i.e. don't have immigration status to qualify for public benefits. There's an amount of county money that's restricted that folks have access to, typically around certain emergencies. And then, like we said, refugee status. And so we spend a lot of time in the safety net, for example, working with families in all of these situations. So I may have a family, for example, who is in the process of trying to obtain refugee status. One person in the family. They also may have other folks in the family who don't necessarily qualify for that. So they're of mixed status, right? And they may have entered our healthcare system, for example, under an illness or under charity care. So there's a whole lot of ways that people are accessing care. And it's incredibly complicated. And it's just important to know because it's so politicized right now. So again, public versus private, I think, is what's important, right? So people have access to health insurance via work sometimes, via families, and then sometimes it's income-based. For example, we're looking at like Covered California, for example. And with Covered California, of course, that's not open to folks with undocumented status. That said, when the issue in California happens where if people are, for example, traveling state to state and maybe they have California care, right? So, or they're in another state and they have access to health care. If they're traveling for agricultural work, for example, their health care doesn't necessarily transfer. And that's also important because what that means for them is fragmented care in a lot of ways. A lot of what was recommended around cultural mobility and healthcare. So some of the obvious barriers, I think, to kind of build on what was already said. The way I kind of structured talking about this really has to do with the physical barriers. We have people's individual barriers or emotional barriers, and we'll go from there. But I think it's important, the main one, obviously for a lot of immigrants, is how important this process is, what's at stake for them, right, to come and access care. So fear and isolation are really big factors, I think, as a healthcare provider, that it's really important to notice, acknowledge, ask about. One of the issues that comes up a lot when I work with folks who don't necessarily know what kind of healthcare services are available and where they're located. Like I said before, folks who are traveling, right? Folks who are living in one area, perhaps to work in another, who have families going from county to county or state to state, particularly agricultural workers and families of mixed status. Their care is really fragmented and they don't necessarily know from state to state what they can access and what exists for them. The other thing that's coming up a lot is scams and insurance. So a lot of families I've seen over the years who have signed up for this care or that care, and it turns out that it's actually not appropriate care. It's not, it doesn't really exist. And a lot of people have been sort of taken advantage of in those settings to try and access care that they can't actually access. So they take a big step to actually try and apply for a service, and it turns out that it's not active. So like I said, fragmented services. Also, folks, when they access services, a lot of the services aren't kind of one-stop shop services, right? So they'll qualify for one thing, they'll have to then go somewhere else, and they'll have to go somewhere else. And for people that are new, I mean, I see people who have really newly arrived. They've been, in the United States for a week or two. It's really different to see somebody who knows their way around to say, I'm sorry, you have to actually go to this place to get this piece of your care. For example, I'm sending you for an x-ray, we don't do this x-ray here, and you have to go here. Where's that? That's it's something that we don't necessarily think of, particularly when we're living in an area that we're really familiar with. I have lots of families that are like, which bus, do I take for that? Do you have a map? And it's literally a mile, but I mean, we take those things for granted. And obviously, folks that are working or that are working, day laborers or folks that are working retail, that kind of thing. The clinics often aren't open when they need to access care. So those are just basic physical barriers that people have. In terms of emotional barriers, obviously a whole nother set of issues, right? So often interpretation. I appreciate that you talked a lot about interpretation. That's a huge issue. Lots of healthcare providers are somewhat fluent in certain languages, and it's all that exists. That said, when you're talking about medical treatment, when you're talking about consent, those kinds of things, it's really important to have appropriate, available translation. And, you know, most of the time it's available, and in most safety net institutions, and sometimes it's not. Using a family member is secondary. And I've been working in the community I work in for a long time, and for example, we work with a lot of Guatemalan folks, and for them, the main non-Spanish dialect is mom, and there's like one mom interpreter that lives in Oregon, and he's always the one that we have to call, but one. And so there are a couple people in Alameda County that we use that we know that speak, that are certified, but really if we have to go through the language line, it's one dude. Nice guy, but one dude. So lots of families have trauma in their backgrounds, right? Why do people come? People come for lots of reasons here. The issue ends up being very politicized, I think, like we talked about, but again, when we talk about this as immigration policy, I think oftentimes we stop at the point where we talk about why people come, right? Obviously I'm a good liberal, but what things are we responsible for as this country that creates the living conditions in the countries where they come from? Whether that be war, whether that be immigration policy, whether that be drugs, whether that be crime, all those things. And we in the United States have a role in that kind of issue. So again, like I said, quality interpreting is often a big issue. And then immigrants sometimes enter the healthcare system for the first time when they come to the U.S., right? And a lot of times they'll enter pregnant. That happens a lot in California. And they may not have another experience of ever having seen a healthcare provider, depending on where they're from. And that's also something us as healthcare providers, it's important for us to acknowledge that, to think about that, to know that, because that's a different experience if you day in, day out see patients and you're just used to seeing patients that have experience as being patients, right? So there are also, like I said, practical barriers, right? So sometimes one of the things that I did my doctoral work on was a program that we call Bite to Balance, and it was a program for families who lived in communities that didn't have access to healthy food, right? So that they were living in food deserts. And this was some years ago now, but one of the things that we did was we created an opportunity that was both treatment in getting people bags of fresh, healthy produce, but also it was the intervention, but it was also the incentive. So coming in for our groups really enabled people to also go home with a bag of locally grown veggies and fruits. So that said, we did that program as a part of a grant, and people had to come in and access care. And for them, it was often families that had mixed status. So maybe one person, for example, was working and not everybody had access to health care. One of the things that we did a lot was the one person who could qualify would maybe then be able to sign up for SNAP, which used to be food stamps and is now just the supplemental nutrition program. And even that, like we said, because of the issue around the new pressure for the public charge, for us in this program, it was a huge issue. Not just because people were, quote, too proud to get services, which I think is often does come up. But the other piece is that if the perception is that when you qualify for these services and you apply for these services, that then comes back and follows you when you apply for having, for your status, it's a scare tactic. And it was starting to come out in our community when we were working in this program, but it's not really a scare tactic anymore. I mean, we can't really guarantee people that if that one person signs up for those services, that we can't really guarantee that they won't, that won't affect their family status in the future. And that's a big deal. So sometimes to qualify for services, people need to have proof of income. They need to have social security numbers. There are cases where people are, using a social security number that may not be theirs, that may be somebody else's in their family. Those are scary things to access, but at the same time, when you need care, you need care. And so sometimes when people are correcting situations that occurred historically, those things come back and are hard to undo. I have a very good friend who came to the U.S. And worked under somebody else's social security number, many years. It was so complicated and so difficult to come back and fix. And she did, but it was not easy. So a lot of times people need to have rental agreements. They need to have leases in order to come and prove that they qualify for services. And again, like I said, they need to, a lot of these, we don't necessarily guarantee anymore that signing up for these services will protect people's future status. And then again, we talked a little bit about systemic barriers. So as healthcare workers, right, we need to be clear about what expectations we have for people, just for our own personal biases, but also systemic, right? So, for example, just acknowledging that the experience, like I think we heard earlier, isn't necessarily an easy experience. All of these things aren't necessarily like, pick yourself up by your bootstraps and, some people's bootstraps are just not that strong, right? And that's actually okay because, it's a challenge. And I think it's really important for us to acknowledge that it is a challenge and not just kind of go, okay, you live here now and, now you do like we do as the Romans do, right? Like we say. we have to make sure that we're making clear in our own selves that the expectations that we set for people aren't too difficult to measure up to. And then also just a basic understanding. So that's what today's about, right? So as you enter into your experience as a healthcare worker, as you see and hear about a lot of these things that people are going through to be able to just live, right? To be able to just live with their families. 19 years, 12 years, 8 years, 10 years. I mean, all of those things, taking the risks about if I do this, am I going to actually, have to leave the country? And when I come back, is it going to come back on my family? And all of those things are really, really profound decisions that are very individual and really important for us to understand that, we don't necessarily have to have a role in them, but it is really important to know where you stand. And again, I also hope that most of us just draw the line with these kinds of things, just listening to our patients and not taking a role in restricting services. So then the other issues are public health issues, right? So when we mandate vaccinations, when we talk about school health, when there are epidemics, we can't pretend that these issues are just not there for immigrant communities, right? And I think sometimes if we don't understand that, then there isn't necessarily a place for them to access these kinds of services, right? If you just restrict services, what happens when you have some kind of epidemic, right? What happens when people need to get vaccinated and then we sort of say, well, sorry, you don't qualify. Is that ethical? Those are really important questions. I mean, I would say no, but, some people would disagree. So again, then national health, international health, when folks come here and they're in the process, for example, of becoming refugees, for example, they're trying to get refugee status, sometimes they will spend time in various facilities that there's theoretically healthcare act for them. And so I'll see a lot of patients who come in, for example, who spend 4 or 6 months in another facility, and they'll come in with fragmented records, and we're having to sort of figure out, okay, what is it that you need, and what is it that your lawyer wants you to have, or what is it that you need to have for your family in order to be able to, one, start going to school, because all of these things matter for them, and the things that sort of drop off or that fall out for them are really difficult for them to figure out, okay, if this, then this, I guess. And then again, what other kinds of services are covered? So do people have behavioral health services? What Medicare-based services are going to be covered for certain immigrants, documented and undocumented? These are the other things that are now kind of part of the national discourse. Whether we're even, whether we're going to restrict certain services, even to people who have immigrant status, and these are all part of the national discussion. So some of the solutions that I'm personally interested in, obviously, we've talked a lot about healthcare reform, we've talked a lot about immigration reform, we've talked a lot about Medicaid expansion. These are some of the things that are in process in a lot of places, right? Expanding hours, being open on the weekends, open in the evenings. All those kinds of things are things that clinics and hospital settings are looking at. Outreach to certain communities, making sure that they know, that this particular service exists and is available to this community or that community. So these are things that are all kind of in process. And these are probably some of the things that some of you are even working on, or will work on. And the other thing for me, I would sort of offer to this group and to any group really is challenging for the future, like what do we actually want to see? So we're looking at the things that we're doing now, but there's a gap. Obviously, we're talking about it. But if you're a funder, these are some of the things, or if you're working for an organization that does fund, for example, funders could, for example, be less restrictive with funding, right? They could, because private foundations don't necessarily have the same rules as the federal government across the board. There's a lot of examples of that. Reducing the burden of reporting, right? Those are things that are possible from the perspective of a funder. And then just really funders in general understanding the issue. I think some funders really do, particularly if they specialize in various areas. I think the California Endowment is one of those places, the California Healthcare Foundation. Some of these organizations are really looking at innovation and looking at how to reduce these burdens. And others, are doing less of that. And it's our job, I think, as providers to be able to step up and say, hey, here's the challenge we're hoping for. These are some of the issues I've read and have thought over the years in talking to people that, folks that particularly advise immigrants on what issues exist for them, right? What funding sources, what services they qualify for. There are organizations that have them. Sometimes they're called patient navigators. And sometimes patient navigators are really the ones who are very knowledgeable about those services, and sometimes not. But to make sure that is a priority, an institutional priority would be good. Figuring out some way to subsidize insurance, right? Or creating even a self-insurance, right? For undocumented folks, there's lots of ways to get around some of these traditional funding restrictions, I think, but it does involve kind of thinking outside the box. So there could be a foundation, for example, that really did handle insurance for that. There could be a hardship pool. That's something that I read about over in some states. They're sort of talking about figuring out a way to do a hardship pool within their insurance. So this, I'm not going to turn this on. This is actually just a link to a commercial. We talked about 187. It's sort of coming back around. This is a link to Insurance Commissioner Steve Poizner. Has a commercial out right now, and he's literally, blaming immigrants for the status of California's funding issues. And it's profound because it's actually on TV, on network TV. And that's our tax dollars at work. And there's lots of examples. So these are just some resources that I kind of put together. Again, a lot of what I'm talking about is Central America related because that's largely my own personal experience and professional experience. That said, it's not limited, but these are somewhat limited. There are a few films. If you want to kind of familiarize yourself with more issues around what bridges people cross as they're having this experience, these are all, pretty well done, interesting, good, nice things to kind of put under your belt as you're walking into the healthcare arena to understand what it's like, or at least to appreciate some of the challenges that maybe you hadn't previously. There's a great podcast that's called In the Thick. They have dealt recently with a lot of this, particularly the separation issue, particularly a lot of what individual states are doing around access. And these are a couple of pretty new books. Dear America is really, really timely. It's a story of a millennial who doesn't realize that he's undocumented until he does like what everybody else does to go get a driver's license, and he finds out his green card's fake. And he has to sort of go through this whole experience, but he ends up actually being an intern at the Washington Post, and it's his whole story, and it's really interesting. And The Line Becomes a River came out last year, and it's actually the story of a man who was an INS agent, and who, it's, the reason it's called The Line Becomes a River is that the idea is that the line between the U.S. and Mexico really was a river, right? So it's all kind of intertwined with history and people's real experience. And I think, just to hear and read, kind of what that experience is, that, it's not really the cartels that are cashing in at the border. So, and with that, I'll take any questions.
First, thank you for providing additional insight into the individual journeys that we as health professionals should be cognizant of. Because again, from the population status, we kind of understand the importance of documenting all of that, but it's really important to take an empathetic approach as well and really understand those individual stories. So it's really nice to be reminded of that. So same question that I asked the first presenter is, what concrete action steps would you advise people who are going into public health and into clinical work? What can we do to make some indent into this really complicated issues around immigration status and mental health with regard to that?
I think this, courses like this, I wish they were available to everybody. I think that's probably the most important thing. Go out of your way to learn whatever you need to learn to reflect the experiences of the people that you work with. I think for me that's probably the answer, right? For me, this is where I live and what I do and who I work with and who I live with. But at the same time, it could be different in another place. And so, I appreciate having the knowledge of what anybody's going through to access care, but at the same time, we
Oh, we do have one question.
Sorry. So I think through the discussion.
Sorry, but go ahead.
So I think through these discussions, we've had an opportunity to really get an idea of what the experience is like for immigrants going through this process. But as someone who's actually implemented programs that try and help these people, I was curious as to what your experience is like trying to institute things like that. Communities typically welcome to programs like that. I know you talked a little bit about funding and how that can be kind of a chore to obtain, but I was just wondering if there's anything you'd like to expand on a little more.
I mean, I think in my experience, I think in funding, you have to know your community to be able to know what you're applying for, right? So I mean, I think if you're trying to do an innovative program, if you have an idea, get people on board for whatever that idea is, but at the same time, you want to make sure that the funder that you're after, that you create for them what it would look like, right, for them. So you know what their restrictions are, but you can offer a challenge to them. And some organizations won't have thought necessarily until they sort of read that. And I think, they're people, right? So it's our job who also work with the people on the front lines to be able to say, hey, not that people who work in those organizations don't have experience in that way, they do, but it may not be as recent as yours. And it's helpful to think about it from a perspective other than the one that everybody else applied for, I guess. I mean, I don't know, maybe this is something you'd want to answer.
I can give a concrete example. When I was at the California Endowment, one of the issues was healthcare coverage for undocumented children. So we felt like that was going to be the first step to breaking through, again, what are the structural and policy barriers that make people who don't have immigration status ineligible for something as basic as Medicaid. And so what the foundations decided to do, and I think this is actually a good case study, several foundations, not just the endowment, but several of the other foundations, ended up pledging literally hundreds of millions of dollars to pay for the insurance premiums, and then convince large health plans like Kaiser and HealthNet to provide the insurance to these children, and that the foundations were actually paying their premiums. And the theory was that if we got enough of these health plans in enough counties to cover enough children, that would put pressure on the state of California to change its Medicaid policy so that Medicaid would cover them. It took about 15 years of paying those tens of millions of dollars of premiums. And so again, if you wanted to do a return on investment, you could question whether or not that was the right strategy. But ultimately, we are now in a place in 2018 where Medicaid in California now covers undocumented children. And so the policy ultimately did change. And I think that's, for me, the difference between sometimes you just have to fund the services because the need is there. But ultimately, what you have to do is fund the policy change and the system change so that the dollars that you're using to fund those services can be used for something else.
Yeah, I mean, I agree 100%. I mean, I think that those two things have to work hand in hand. So you have the tried and true services that people continually apply for based on the measures that we're counting, and at the same time, we can also look towards being more innovative and more creative as we go. And there are ways to do that, but it's kind of like dancing with a new partner.
Hi, so I work for Vallejo City Unified School District as the coordinator for the nutrition program. And recently, this past summer, we noticed a decrease in our school meals program, mainly because a lot of the students students who go there are from undocumented families. And so my question is, for those, since you have all these different services and programs that do serve immigrant populations, especially, immigrant populations, how can you help them when most of the time they are afraid to go in because of fear of being deported and stuff like that? So how can you help them with these different services when they're afraid to come to you?
So that's a great example where I would say, again, you can sort of do the one-by-one approach, or you can do more of a system-level approach. And so I would say this would be a really important opportunity to, for example, look at your parent-teacher association. Are those immigrant parents coming to PTA meetings? Are they coming to other kinds of school meetings where they're learning about not just the education of their kids, but the other services that might be available? So that, again, you're not sort of putting the burden on that individual family, but that you're really creating a system-level conversation about what services, what are the risks and benefits, the fact that school lunches has nothing to do with public charge for now, and yet there's that understandable fear and confusion among immigrant families. And so I think it's both doing that individual level, but also thinking about what are the ways in which immigrant families, in this case, can be more involved in school overall. So that isn't just a conversation about school meals, but it's also about how they continue to be engaged in the education of their kids and what other services that might be available from the school, including to them as parents.
It's a great question. The program that we created, actually, we went as, and this is another strategy you could use, but what we did was recognize that we couldn't necessarily use a school lunch policy or, something like that. So what we did was went to a local farm, right? And so, that's also an option, right? So where do the parents work? A lot of them might be ag workers. I mean, perhaps they work in, communities where some of these programs could be funded through that way. We actually ended up, you end up with a lot of what we call unintended consequences. And sometimes the unintended consequences are great and surprising, even for, those of us who think we're trailblazing. So, I think when you design programs, you really have to be thinking not just of the end user, but you also have to be looking at how people access them and how people know they're available. And it's by talking to people and looking and listening to what their barriers are.
I actually was just going to add to you that, and I'll get your contact information, but I think partnering with Fighting Back, faith-based organizations, and Solano Community College, Touro, Cal Maritime, so we can help you kind of figure out how to, because we're all doing work with different types of populations, so we can assist our school district in getting the word out and the work that we do daily at the Family Resource Center. I'm on the Fighting Back board, so using that as an example, Vallejo Together and several others. So then it's a kind of a community solution. There is a group of organizations in Vallejo, only because I'm more involved in Vallejo than other areas, that are working around immigrant issues. And so there is a networking system, so we can try that way to try to get the word out. Because I've gone to several of those larger meetings, and there's definitely, especially when Trump first went into office, a lot of fear. And I think people came to the meeting out of fear for solutions. But now we've developed this informal network of communication, so we can kind of help in getting the word out to make sure that they have access. And at times we may have to go to other communities as opposed to having communities come to us. So I'll get your information.
And I actually, I did share the lecture series flyer with our superintendent, so that's actually on our district Facebook page, so that's open to everyone to see. So I'm hoping people would come and listen to the speakers as well, just to learn about it.
Yeah, Dr. Clark was actually at our violence prevention event that we had a few weeks ago, and he's on several boards, so we'll make sure to keep him in connection how we can help out.
Do we have any other questions? Well, Thank you all once again. It was really a great honor to have Ignatius and Michele Alberts here today. We have slides available on Canvas website, and I know that we've had a little challenge with our survey, but I think it's been taken care of. So you can go ahead and ensure that you complete those surveys at the end of the lectures, and we look forward to seeing you all next week. Thank you.